Hello and good evening. Welcome. We just had a few more people sit down and then we can start the show. I'm Dr. Alan Schell from the Wolper Jewish Hospital and welcome you here tonight. Part of our Wellbeing program in public education, preventive health and professional information from our guests this evening. Tonight we're also partnering with Diabetes New South Wales ACT, and we have a very special person here in Angela Blair, and also her friend Monica Smith, I believe, is here. But Angela's going to give us a quick talk about Diabetes New South Wales and ACT. Over to you, Angela.
Hello everyone, how are you all tonight? Good. So who is already registered with Diabetes with NDSS? So you know a little bit about it. Diabetes New South Wales and ACT is the agent for the NDSS in New South Wales and ACT, so we look after it. So I'm just going to run through some of the points around NDSS and us as a member organisation. Can't actually see my slides, so I don't even know what they say, to be honest. So we're a not-for-profit organisation, and we look after and represent people living with diabetes. And I think that's a very important role. And our mission is a life without the complications of diabetes. And that includes people living with diabetes already and those at risk of diabetes. And our priority is really about the wellbeing and health of people. We are a member-based organisation, so you can actually join Diabetes New South Wales. You can get the magazine, we have monthly newsletters and discounts, but I'm not here to talk about that, so I'm here to talk about NDSS. So the NDSS has been around for quite a long time. Back in the day, in 1987, and in 2007 we added a few more items to the list, including pump consumables, and just this year we've added continuous blood glucose monitoring for children under the age of 21. It's funded by the federal government, so it's quite a lot of money, and there's been quite a few reviews with it that have happened recently. How do you register? You've got to have been diagnosed with diabetes and have a Medicare card. It's pretty important. And that's affected our armed forces just recently because they now also have to have a Medicare card, where in the past they didn't have to. What are the other benefits of NDSS? A lot of it is about, it's not just product. A lot of people think NDSS is around products for diabetes, so that's blood testing strips, insulin, pen needles, pump consumables, but it's actually not. The majority of the services provided are around programs and support. There's lots to do with gestational diabetes, there's lots to do with young people living with type 1 diabetes, adults living with type 1 diabetes, as well as all the other programs and events that we run. We do have a 1300 number that you can ring Monday to Saturday mornings and speak to a diabetes educator, dietitian or exercise physiologist. So they're on tap. They actually only answer general things. They're not there for clinical advice, but they can actually advise you where else to go if you haven't got support in your local area. We also have lots of resources. Some of you may have picked up the fact sheets, the information sheets out the front. There's actually 43 of those, and there's some versions in other languages. If you want to actually see what else is available and you've got access to the internet, just jump online, go to Diabetes New South Wales, and you'll find listed all the sheets, and you can just download them off the internet. So registration, there's been a few changes to the NDSS in the last 12 months, and the main one is that all product now is only available through pharmacy. No longer do we provide it as a point of purchase. So subsequently our shops and our, we actually had physical shops, they've all closed as a result of that. So if you go into any participating pharmacy now, you can get your product over the counter. It's also a place that you can take all your forms. So if you change and you start taking insulin or a non-insulin injectable like Dietetics, you actually have a form that you need to fill in, take that to the pharmacy, then you can access your pen needles. If you need to go on an insulin pump, same deal. There's lots of forms that you get to fill in. If you change your details, make sure you actually let the pharmacy know so that you can get sent your invites for all the programs and events. Lots of forms. For injecting equipment, it's all still free. The only equipment in the injecting line that you pay for is a co-payment for the pump consumables. So if you're on pen needles, they're actually free, so that means you can change them every time you do an injection. If you do need to change over to insulin or an insulin injectable, just get the form, take it to the pharmacy, and you can access products straight away. With the biggest change, though, was around blood testing for people with type 2 diabetes. This change started on the 1st of July last year, and it's now well into it. So people will go to the pharmacy and they'll be told they can't access blood testing strips. They can still access them. There's a form you have to have filled in by your doctor or your diabetes educator. Take it back to the pharmacy will change it in the system, and you'll have access for strips for another 6 months. It's important to talk about your results, and that's part of this process now that we want people to actually go back and have that conversation. So there's a form to fill in that you just need every 6 months. The other big change is no longer can you have prescriptions written for blood testing products. It all has to go through NDSS. A lot of people questioned it, and a lot of people got the wrong idea. So some of the services that you can access is the helpline, as I said. Speak to a diabetes educator, dietitian or exercise physiologist. We actually have translators available as well. You can go to our website, download information, and there's lots of written resources out there as well. So there's lots to do with NDSS. We represent New South Wales. So we have lots of programs running in various areas. If you're interested in attending any of the NDSS programs, all you need to do is go online, or you'll receive an invitation in the mail. I'm off to camp tomorrow, so we actually run camps for kids with type 1 diabetes. So we've got our parent and child camp starting tomorrow morning. So it's going to be a very hectic couple of days with 60 kids with type 1 diabetes and mum and dad. A lot of fun. So there's some of our programs. And there are our contact details. So the main one is that 1300 number. So if you want to jot it down if you ever need any support or assistance. And that's my 5 minutes. Thank you very much.
Thank you.
Thank you, Angela. Okay, so introducing this evening's topic, living with diabetes. World Health and others say there's approximately 400 million people in the world with diabetes, and in Australia I'm told there's about 1.25 recognised to have 1.25 million, so that's about 1 in 20 in the population, quite a large number. So a significant disease, and with that in mind we have a number of significant experts, professionals who are going to talk to us about this topic. But of course we're going to introduce Julie McCrossin, our journalist, radio person and celebrity, who's going to do our Q&A. So I'm going to introduce Julie, who will then introduce our guest speakers and panellists. And as always, Julie conducts the evening in the Q&A, so you'll have an opportunity to ask questions, and we'll have plenty of good people here to provide some answers. Maybe not all, but certainly some good ones. And a reminder that if you have mobile phones, please put them on silent or turn them off. And we have lots of information out the back at the end of the meeting. So without further ado, I'll hand over to Julie. Thank you.
Thank you very much. And I just want to say thank you so much for coming out on this very cold night in the middle of school holidays. We very much appreciate it. Could I invite Professor Bernie Tuch, Amanda Bartlett and Dr. Nasseem Malouf to please come out into the chat pit, and we'll get our proceedings underway. If I could give you that. And I've been asking all our panel to speak into the top of the microphone and to speak very loudly. I'll introduce each person as we begin. Essentially, Wolper Hospital have given me a range of topics to cover, but I know there'll be people who have questions, so I will have question time at least 3 or 4 times before we finish just before 9 o'clock. And I'm absolutely informed that exercise is very good in helping the prevention or the management of diabetes, so I would like a lot of questions from people in the back row, if that's possible. and I'll leap up to you with my microphone. Thank you. It's okay, Alan. I'm always a one microphone girl. It's the way I work. It's just total control. I don't know how. One of 5 children, 2 big brothers. It's how I learnt to do it. Let me introduce Professor Bernie Tuch, who's an endocrinologist, the Director of the Australian Foundation for Diabetes Research, Director of the New South Wales Stem Cell Network, an Honorary Professor of Medicine at the University of Sydney and Monash University in Melbourne, and a non-executive director of the Living Cell Technologies Company, which is a listed company. Would you please make him welcome with a round of applause? If you could pick up the microphone, please, Bernie. We've had an indication of some of the services that are available, but let's go back to the basics for people who may not know about diabetes. What is diabetes, and particularly what is the difference between type 1 and type 2?
Thanks, Julie, and good evening, ladies and gentlemen. Basically, can I just ask before I answer the question, be like a good politician and ask my own question, which is how many people in the audience have diabetes? Put your hands up, please. Good. How many people don't know whether they've got it or not? Wow. So the figure that you heard previously, and I'll come to answer your question in a minute, is that there may be 1.25 million people registered with the NDSS who have diabetes, but in effect there's probably another 500,000 people, another 500,000 Australians who have it but don't know it. So go and get your blood sugar levels checked by your local doctor during your annual check, and you'll find out soon enough.
Why is it important to know?
One of the issues is that although you may have no symptoms from diabetes, which would take you to your doctor, if you have high sugar levels for many years, you're likely to develop problems with your eyesight and perhaps your kidneys, so that you will go blind or need a kidney transplant. So it's in your best interest to know whether you have diabetes, and if you do, to manage it appropriately to avoid these sorts of things, and they can be avoided. Now, what is diabetes? Back to the question. So diabetes, of course, is a situation, a metabolic disorder, which is characterised by elevated sugar levels, elevated levels of glucose in the blood. So normal levels might be anywhere between, giving you numbers, between 4 and 7 millimoles per litre. You might be higher than that, and we'll talk later about how you diagnose it. It could be 20 or 30. And basically, people with type 2 diabetes, that's the commonest variety. It affects 90% of that 1.25 million, have 2 problems, whereas people with type 1 only have 1 problem. People with type 2 diabetes, no symptoms, 2 problems. They are, 1, their insulin-producing cells of their pancreas do not produce enough insulin. First problem. Second problem, and you've got to have both, is that the insulin which is released in response to your meals, in response to sugar, doesn't act as efficiently as it should. So 1 is called insufficient amount of insulin. 2, there is increased resistance to the insulin. It doesn't unlock what you need to do as a person without type 2 diabetes can. That's type 2 diabetes. And type 1, well, I said there's only 1 problem. That's perfectly true, much more serious to a large extent, because in effect in such people, and it's a younger population generally that get it, average age of peak incidence is the age of 13, is that they lose all their insulin producing cells. And without any insulin producing cells, you're in real trouble. You will die without it. So if you remember back to the 1920s, before my time and before most of your time, I would suspect, basically it used to be called the wasting disease. Of course, basically insulin is needed to build up protein, to build up fat, as well as to control your sugars. And without insulin, those people with type 1 wasted away and died. Banting and Best came on board, Nobel Prize, and in effect together with a few others in that particular time in Toronto, Canada, pointed this out, and insulin came into being, or rather it was recognised, and it has been used to save lives ever since. So type 1, one problem, but you die if you don't treat it. People get symptoms very quickly. People with type 2 diabetes, 2 problems, rarely get symptoms, which is why most people, why there's 500,000 Australians sitting out there with diabetes, or probably with diabetes but not knowing it, and putting their health at risk.
I'm going to get a little bit from each of the others, but I just want to stay with you first, and then I'll come to our first set of questions. But you revealed, and you said I could reveal it to the audience, that you yourself have diabetes. So how does a man with expertise and knowledge still be diagnosed with type 2 diabetes? What does that tell us about type 2 diabetes?
I guess the answer to that is that, in fact, you inherit certain genes, and whilst you can do a number of things in order to be able to delay the development of problems, you can't necessarily prevent it. It tells you that doctors are not God, and that they can't effectively, all they can do, in my case, all I did was, for other reasons, and I had no knowledge that I would get it. I was in the field of diabetes. I was measuring the sugar levels of my patients, and I said, well, if I measure theirs, I should measure mine. And gradually, over a period of time, it kept climbing. And so, sorts of things are plenty of exercise, keeping yourself as trim as possible will reduce resistance. And whilst I can't change the amount of insulin my body produces to any major extent, you can certainly do many things to alter the resistance. So when you get out of here, make sure you walk rather than take the escalators, or rather than taking the lifts. Keep up your physical activity, and you're likely to be able to control or reduce the chance of developing diabetes if you are programmed to do so.
If I could come to Amanda, and Amanda Bartlett is a credentialed diabetes educator in private practice, a registered nurse and a qualified midwife, and has a graduate certificate in diabetes education from the University of Technology in Sydney, where she's a guest lecturer there and in other locations, and she chairs the Diabetes in Pregnancy Special Interest Group with the Australasian Diabetes in Pregnancy Society. Would you give her a clap of welcome too, please? Just before I come to the role of a diabetes educator, tell us about diabetes in pregnancy, because I know, just as I was shocked when I heard Bernie had diabetes, I was when I heard that Cathy Freeman, the great Aboriginal athlete, developed diabetes in pregnancy. So tell us about that.
Thanks, Julie. So there is a mild form of diabetes which occurs during pregnancy, and it's caused by the placental hormones. So generally it occurs around about 6 months. It's important to be tested for it. All women across Australia are now tested. Then there are women who have type 1 diabetes or type 2 diabetes who wish to get pregnant, and their diabetes will get worse through the pregnancy because of the effect of the hormones. So we work very closely with these women to make sure their blood sugars are perfect at conception and throughout the pregnancy so that the baby's not affected.
And can you stop having diabetes after you've got it from pregnancy?
So women who develop gestational diabetes, 50% will go on to get type 2 in the future. And what we recommend is that, exactly as Professor Tuch has just said, that to maintain your weight within a healthy range will help prevent this. So stay fit, stay active, eat well, keep your BMI normal, and avoid abdominal fat, not pregnancy fat.
And remind us about BMI, what that stands for?
Body mass index. So it can be calculated for you, and depending upon your background ethnicity will depend upon what you need to be in.
So in order to illustrate the role of a diabetes educator, can you describe what you classically and most commonly will do when someone comes to see you? So first of all, how do I get to see you?
You can self-refer, or a GP might refer you, an endocrinologist might refer you, or if you're pregnant, an obstetrician or GP. But I also, we see people who self-refer all the time. And a typical consultation would be an hour in duration, and usually at diagnosis. So our roles as educators are to here to support the individual and the family. At diagnosis, there's a lot of shock. Sometimes there's anger, sometimes disbelief. So our role is to hear this, to support the individual, and to provide education around healthy lifestyle, healthy eating, and managing the diabetes so that complications don't occur.
Why is exercise important and not just weight loss?
Exercise is really important because it will make your insulin work more effectively. Thus, it will usually lower blood sugars across a period of hours after the exercise. It's complicated. Some forms of exercise will make the blood sugars rise initially, but there'll always be this nice effect afterwards of a lowering of the blood glucose levels. So it's making that insulin that wasn't so effective, that is being rejected, it's making it work more effectively in the body.
So exercise is literally as important as diet?
Absolutely.
Look, thank you very much. I'd like to come over now, if I may, to Dr. Nasseem Malouf, who has a PhD in human nutrition and postdoctoral qualifications in that area. He works at the Diabetes Centre at Prince of Wales Hospital and in private practice, and he's written a book, Diabetes and the Metabolic Syndrome, Eating for Prevention and Treatment. Could you begin by explaining, a clap of encouragement too.
Thank you.
I wondered if you could begin by explaining metabolic syndrome. What do those words mean?
You know, the term started back in the 1920s, I think, from a Swedish physician who noticed that there were clusters of problems, metabolic problems that were occurring, including blood pressure, sugar problems, cholesterol problems. And it was just a cluster. And that graduated on 20 years later. They changed the definition of it. And later on, eventually it's graduated till today, and now we know that the metabolic syndrome is a cluster of metabolic problems that occur when people put a lot of weight on. It's essential that they have what we call abdominal fat, visceral abdominal fat. Doesn't matter how big your body is, if it happens around your waistline, there's a lot of weight, a lot of fat internally around your abdomen, it seems to throw the system out. So you end up with either impaired glucose tolerance, meaning your sugars start to creep up a little bit. You might have normal blood fats, abnormal blood fats, not necessarily high cholesterol, but high triglycerides, low levels of what we call HDL cholesterol. That's a good one that protects you from heart disease. You might have blood pressure, you might have gout. So it's an accumulation or a cluster of these metabolic abnormalities that occur as a result of people carrying, it's the most important thing, carrying too much weight. So that's the underlying issue, the weight, the abdominal fat, which seems to result in what we call insulin resistance that Professor Tuch was talking about, as a result of hyperinsulinemia, in other words, high levels of insulin. It's just an abnormal level of insulin in the blood that are occurring, resulting in these increased risk of cardiovascular disease and people on their way to diabetes.
In a nutshell, what's the dietary recommendation to prevent?
There's no such thing as a nutshell when it comes to food. You know that. You read a diet every day. It doesn't matter what book you open, you're going to see another diet, and there's combinations and permutations of diet is enormous. But we know today that there is not one diet for all people with diabetes. And hence, the importance of getting yourself seen individually by a dietitian who works in the area of diabetes, who can tailor the diet to your individual needs, requirements, likes, dislikes, depending on what sort of metabolic issues you have. Do you have a cholesterol problem? We take that into account. Do you have a blood pressure problem? We take that into account. Do you have abdominal fat or a little bit of overweight? Do we take that into account? So all these things have to be taken into account, and there is not one diet for all.
Thank you. Ladies and gentlemen, we have in the audience, who I'll come to later, an optometrist and two audiologists, and I'm not sure if Annie Walsh has come, the podiatrist, but Dr. Tuch will help us on the feet. So we'll talk about some of, I guess, the risks associated with diabetes and what can be done. But let's begin with questions. So if you raise your hand, I come to you. I don't let go of the microphone, but I interact with you in an effective manner. I'll hold it.
Okay. I've been diagnosed with pre-diabetes. I just wanted to know, with pre-diabetes, is it possible to also get peripheral neuropathy which I've got a touch of as well.
Could I come to Dr. Tuch? Can you explain, first of all, what peripheral neuropathy is and what pre-diabetes is?
Well, perhaps I could ask the gentleman if he could tell you what peripheral neuropathy is, because he's experiencing it.
Can you explain?
Okay. Basically, in my case, it's just the bottom of my feet is sort of semi-numb. I haven't lost feelings, but it's like permanent numbness, but haven't lost feelings. So it's a mild touch of peripheral neuropathy. As I understand that, if it's worse, then you can lose complete feeling, and I'm sure you know.
Thank you. So what you've just heard, of course, is peripheral neuropathy is a damage to the nerves that supply the periphery, which is, in this case, presumably the commonest area is, of course, the feet. And it can occur in people with pre-diabetes. I've got one particular patient who has not progressed to diabetes, but does have progressive peripheral neuropathy, pins and needles, as it moves up his legs as the problem gets worse. So the answer is yes, it can happen, and in that situation you want to be very aggressive about keeping the sugar levels as normal as possible in order to try and delay. You won't be able to prevent, but you can delay the progression by keeping them as normal as possible to prevent the progression onto diabetes.
And this word pre-diabetes, in the media there's quite critical reflections upon this notion. Are we medicalising too much of the population? What would you say? First of all, what is it, and do you think it's a useful thing to know about as an individual?
Well, I can go back to Alan when he was introducing us. Previously, we talked about the number of people in Australia with diabetes, and I think the figure you said was 5% or thereabouts of population. Well, over the age of 25, there's 25% of people either with diabetes or with pre-diabetes. So in other words, it's quite a big problem, and once you've got pre-diabetes, you are more likely to develop diabetes in the future, hence the term pre-diabetes. How do you define it? You define it on the basis of either a fasting blood sugar level between basically 5.6 and 7 millimoles per litre, or you can define it as well using a 2-hour glucose tolerance test. So it's a term. There are usually no symptoms. So you're an unusual, sir. You are one of a few people. So, but in effect, who have symptoms. But in most people, they have no symptoms whatsoever. But it's a sign. Unless you do something, you will develop diabetes in the future.
Because we don't have our podiatrist, can you just explain why it's important for people with pre-diabetes or diabetes to look after their feet and other parts of their body? Can you just explain why it happens and why special care is needed so there isn't limb loss, basically?
So let me just ask the audience, how many people see a podiatrist? Quite a lot, actually. Well, there is a good answer to the question, or to the issue. The problem with diabetes, of course, is you can develop long-term complications. The parts that are relevant to the feet are twofold. Number one are the nerves, and we've just talked about that. The other one is, of course, the blood vessels, usually the large blood vessels. So similar to, for example, the blood vessels that supply your heart, your brain, they also supply your lower limbs. You can have problems with your heart, you can have problems with your brain, you can have problems with your lower limbs. And the issue is that, therefore, if you got, for example, or developed an infection, say you lost feeling in your feet, you walk without shoes and you walk on a nail, you will not feel it. Most people, I don't, but maybe you do, but most people don't look on the soles of their feet. So what happens in that scenario is that you can go on to develop an infection which will spread into your bone, so-called osteomyelitis, and the next thing you know is you may well lose one of your toes or your foot because of the infection. Now, normally you'd expect the blood system to help resolve the problem, but if you have poor blood supply, in addition to loss of feeling, you are a sitter for a problem, hence the reason why we have podiatrists and presumably why so many people here even if you don't have diabetes, but basically you look after their feet by going and seeing a podiatrist.
Thank you. Other questions or comments? Thanks.
I have late onset type 1 diabetes. I only got it about 8 months ago. I'd like to know the latest research on type 1 diabetes. Are you any closer to finding out any more about it?
Julie, have we reached that stage where you want to address that issue? And that was on your list.
No, go for it. I think it's good to do it as the audience requires, yes.
So whether you have latent type 1 diabetes is really diabetes that occurs not at the peak incidence of 13. I can't see your age, and maybe you don't want me to guess it.
35.
35.
No, sorry, 65.
60. So at 21, I think I heard, didn't I? The answer is, of course, it can occur at any stage of life. It's not that common to get it in the 60s, but it does occur. And the answer in that scenario is that the treatment, of course, is exactly the same as whether you get it at the age of 5 or 65. It's the same treatment.
The research, it's the latest research I'm interested in.
Sorry, research into treatment or research into...
Well, yeah, I know there's not going to be a cure, but I just want to know what the research... Is there a lot of research into type 1? I read a lot of articles about type 2, but not a lot about type 1.
Okay, so the short answer is, of course, there is an organisation called the Juvenile Diabetes Research Foundation, and it was set up in the 1970s effectively to address your particular question. Parents of children, no, that isn't your situation, parents of children with type 1 diabetes really wanted a cure for their children, and that certainly is because they remember people with type 1 will die unless they get a treatment. So they really wanted to get their children, not only give them insulin, but prevent complications, but get them off insulin, give them a cell therapy. And yes, there is a treatment available in Australia for type 1 diabetes for people who do not recognise low blood sugar levels. Let me explain. Once you give insulin, you can't control your sugar levels as finely as you can if you have insulin coming from your own pancreas. So you have highs and you have lows. Normally, if you get a low sugar level, you recognise the symptoms. You get sweaty, you get shaky. But a percentage of people cannot or have lost that ability. So you're driving an illustration, a truck driver who has type 1 diabetes, driving his motor vehicle, went unconscious. Or rather, he had no warning symptoms, developed low sugar levels, crashed into an oncoming car, killed the occupants. So for people who fall into that category, you can have what's called an islet transplant. That means you can transplant insulin-producing cells from donors when they die, when they donate their organs under certain circumstances. And the people basically, that's available in Australia, but it's limited to those people who don't recognise low sugar levels because you need to take anti-rejection drugs for life. There are developments occurring in California, and we're trying to bring them to Australia, whereby you put those cells, insulin-producing cells, in a device where you can overcome the need for anti-rejection drugs, and we're developing one of those at the university, in order so that we can make it more readily available to people like yourself and others. That is moving. Certainly the trials in California began a year and a half ago. So we are moving closer to be able to provide that sort of treatment.
So there are developments in this area.
Absolutely.
Yes. Would you like to ask any other questions?
Oh, probably a million more. Will yes, I get hypos, and I sense them now.
Can you explain what you mean?
Well, I do get shaky. I'm aware when my levels start to drop because I'm lucky enough at this stage to get symptoms. But over time, will that decrease, will it? And I won't necessarily recognise that I'm going to get a hypo unless I test.
Not necessarily. There's no natural progression. If that did occur, there is a particular treatment available whereby you reduce the amount of insulin, keep your sugar levels a little bit higher, and people can recover their capacity to feel low sugars. But if that becomes a problem for you, Amanda, sitting on my right, would love to see you.
Can you explain how can you help? And I'll come to you, sir, as well. Thank you.
I was just going to answer a couple of questions around the research as well. There's quite a few studies going on during pregnancy for mothers that have type 1 diabetes, or the father that has type 1 diabetes, where there was the trigger study and the vigor study looking at whether environmental factors or a cow's milk protein that triggered type 1 diabetes, and those results are due out later this year. And there's also the India study where they're following up the neonates and looking at whether antibodies are developing. So there's quite a lot going on in various areas of diabetes. But to answer the question about low blood sugars, as the lady spoke earlier about the NDSS subsidising continuous monitoring for under 21s, if they have reduced sensation around hypoglycemia, insulin pump therapy and continuous monitoring is a way to improve your symptoms, or you can program the insulin pump it will predict that your blood sugars are dropping, and it will cut the insulin altogether until your blood sugar levels rise to an acceptable level, which we choose and we program, and that again starts to allow the person to receive symptoms around hypoglycemia again.
So Amanda, what I'm hearing is it's wise to see a credentialed diabetes educator, because I was going to say, how can the average person stay in touch with research? And that's a very hard thing to do, but through a credentialed diabetes educator or your clinician or your general practitioner, that might assist someone such as this lady?
Absolutely. I think it's really important to touch base with an educator about once a year, review how things are going on and what are the latest technologies and benefits out there for people with type 1 or type 2 diabetes.
What I'd like to do is take a couple more questions, and then we might hear from our audiologists and our, optometrists. But sir, you've got...
My blood sugar level is 6.3, and I'd like to know whether this is borderline diabetes or not.
Is that a fasting blood sugar level?
Yes.
Then yes, it's impaired glucose tolerance.
And so what's the advice?
The advice would be to, I can't see your age or your body weight, but to be exercising daily, to incorporate that into your lifestyle. Try and maintain your weight in a healthy range, and to definitely have follow-up testing.
Everybody I've spoken with so far is as lean as a whippet. You know, what I'm learning is that while weight is critical, it's not necessarily protective. Look how skinny he is. Sorry, Professor.
Okay. I should tell you that, in fact, in India, which of course has a large population, diabetes there occurs in people who are mostly of normal body weight. So sometimes you can be of normal body weight and still get diabetes, but in the West it's usually the other way around. And
so, excuse me, Dr. Nasseem Malouf wished to comment.
And that's to do with, you can be thin generally, but as Professor Tuch was saying, in Indians, and you see that in Southeast Asian women too, once they get a little bit of tummy, a little bit, they don't look fat at all, but they've got a lot of visceral fat, and that's the danger. That's the one that increases insulin resistance and causes the problem. I'm coming back to your question up there as far as hypos are concerned. When someone doesn't have diabetes, obviously they don't need to worry about hypos, and there's a reason for that. The body takes care of it. If your sugars go high, it produces insulin, brings it down. If your sugars go low, I can go out for a marathon in the morning with a fasting blood sugar of 5 and come back with basically the same sugar level. How does that happen? Because my body has a way of bringing it back up when it goes low. So there's a nice fine balance there. When you're on insulin, now you've interfered with the system. You need to know how much insulin you're taking. You need to know how much carbohydrate you're having for those meals. You need to know how to space your carbohydrates over the day. You need to know when to have your meals relative to the amount of insulin, the quality of insulin that you're taking. This is all to do with education. You need to see a dietitian. You need to go to that diabetes centre. You need to go to Amanda. You might need to go to Prof. Tuch. You need to go somewhere. Look, in Australia, we are so fortunate. It's all available to you. The education system, I work in a diabetes centre, I've been working there for 30 years. It's free. It's available. You can come and see me for 20 years if you wanted to until you learn it. Learn it. It's all about education. It's knowing what to do. A lot of people go by guessing. They end up in trouble.
Could we clap our democracy that has delivered this free service for 30 years? I don't think we should take it for granted. I'm the daughter of an orthodontist who didn't like tax, but tax is the key to civilization. Just throwing that in as a comment.
My comment would be that education and facts are the important thing in civilization. My name's Robertson. I'm part of a group, a global group, that reverses type 2 diabetes and gets people off their medications. I have a question for Bernie and Nasseem. In my hand I hold a medical text from 1923. This is the most authoritative medical text of the day. It's the 9th edition of the Principles and Practice of Medicine by two very well-credentialed people, Sir William Osler and Thomas McRae. These are professors of medicine in the US and in London. Now, back then, 100 years ago, it was widely known by GPs across the Western world via that definitive text, or the most authoritative text of its day, that the main cause of diabetes is, and I quote, excess of carbohydrate intake. Clinically, one meets many cases in which glyceria is present as a result of excessive ingestion of carbohydrates. So this, 100 years ago, doctors knew more than diabetes specialists today, in my opinion.
So what's the question, sorry?
The question is, if 100 years ago the cure for type 2 diabetes was documented, known and effective, and the human body hasn't changed in 100 years, why do all the mainstream diabetes entities in Australia say ridiculous things like, given that diabetes is defined by excessive blood sugar, which is driven primarily by excessive consumption of carbohydrates, why do we have ridiculous, harmful things in diabetes advice like healthy eating for people with diabetes is no different from what is recommended for everyone else, when we know the single biggest driver of the problem of excess blood sugar in type 2 diabetes and of the amputations and of the blindness is excessive consumption of carbohydrate. Here also I have a 2017...
Could I just get a response to that? And I'll give you another, just so we don't hit too much. I think each person may wish to respond to this. Do you want to begin, Bernie?
So I guess the question is, when you get to be 66, you get to see things in life that you may not see when you're 26. And I'm guessing what I'm not trying to advise, I guess, is that life goes as a circle. What is today is not tomorrow, and often it comes back, turns out to be acceptable at some stage in the future. I think your point that you're making is that you would prefer a person to have a low carbohydrate diet. I don't think we talked about glycemic index in those days, and that would reduce the chance of you getting diabetes perhaps, or once you've got it, as a way of trying to minimise what else you need to do to be able to manage it. Well, that's partly true, but don't forget that type 2 diabetes is not just about insulin resistance, which carbohydrate's about, but also about the loss of insulin-producing cells, which I'm not aware of is connected to how much carbohydrate you eat. So you have a dual problem. And type 2 diabetes is progressive. So I accept that certain diets, and the one you're describing, can get people off their medication in the early stages of diabetes. But since type 2 diabetes is a progressive disorder, I struggle to see how long-term diet alone will solve the problem.
I mean, that's a very good point. It's two things. Are you producing enough insulin? But assuming that's stable, why do people get diabetes? Otherwise, they get it when they gradually start gaining weight. Weight is the driver. You know, we're hunter-gatherers. We've been hunter-gatherers for 2 million years. If you put a caravan on a 4-cylinder car, what happens to the car? What happens to that motor? How much harder does it have to work? It's that weight that's driving it all. Now you can gain weight. You don't have to eat carbohydrates alone to gain weight. What if you ate a lot of fat, which we see in Western countries? Why do we think we've got a weight problem in this country? It's not only because we eat carbohydrates, it's because we eat a lot of refined carbohydrates and we don't eat enough of the right carbohydrates. And also we eat a lot of fat. So our total calories intake in relation to the amount of activity that we do is too much. It's like putting more money into your bank account than you're actually withdrawing. It's going to go up. And once that weight goes up, for whatever reason it is, be it fat intake, be it carbohydrate intake, be it alcohol intake, be it refined sugar intake, you're likely to get that insulin resistance to balance out what Prof. Tuch was saying. Now, once you've got the diabetes, what do you need to do there? I'm with you. I developed a pyramid in 1993 when the Diabetes Australia or New South Wales was always saying the bottom of the pyramid is carbohydrate. Eat carbohydrate as the basis of your food. Well, these people have got impaired glucose tolerance, they've got diabetes. How could you tell them to eat more carbohydrate? I'm with you. But the question is, how much less? Yes, when you come to me and you're a big carbohydrate eater, especially a refined carbohydrate eater, chocolates, cakes, biscuits, soft drinks, what's the first thing do you think I'm going to tell you? You cut those ones out. I might even reduce the amount of rice and pasta and breads that you eat too, depending on what you normally eat, depending on what your glucose status is like and what sort of medication you're on. So that flexibility is there. Don't blame carbohydrates for everything. The trend now is reduce your carbohydrates. Some people are actually cutting carbohydrates out completely. Now, once you cut carbohydrates out completely, what have you done? You've cut out something like 35 different nutrients that your body requires that you would otherwise have to take in tablet form or in vitamin form or mineral form as supplements. Would that be a healthy way to go long term? No, not at all. Not in my opinion. Yes, compromise on the carbohydrates. Get the benefit of fruits, breads, cereals, and the vitamins and minerals that come with it, and the fibre that comes with it, help you go to the toilet at least. Enjoy all that. Take the benefit of it, but by the same token, compromising relative to what you normally take, and that will improve your glucose status.
Thank you. Amanda, would you like to add anything?
Not really. I think they've answered really well. But I, as a mother of 3 children and a diabetes educator, and I've been in health for over 30 years, I would say food is social. It's meant to be eaten as a family. It's meant to be enjoyed. Moderation is correct, but fad diets will not work. They won't be maintained.
Just one. I must share, but I'll come back if there's no questions later. So just one more now.
It's ridiculous to say that a diet that featured in the most authoritative medical text in 1923 is a fad diet. I was disappointed with the 2 gentlemen. I was impressed initially with Nasseem's mention of metabolic syndrome because I thought he was on the right track, and he is somewhat. But Nasseem, you must be aware of the sort of detailed random controlled trials that show the removal of carbohydrates and the substitution with fat improves every aspect of metabolic syndrome. It reduces weight, it reduces triglycerides, it reduces blood sugar, it boosts HDL cholesterol, it reduses blood pressure, and
it can, yes.
Not that it can.
Hold on. Let him.
It can.
Okay. So the standard result is that it does, and I'm sorry. I want to give you a decent go, but I have to give them just a quick reply, and we'll go to another person.
You can get improvement in all those metabolic syndrome risk factors by not reducing your carbs, certainly would help improve your glucose status immediately. And it would indirectly affect your HDL and your triglycerides. Yes, that will bring that down too. And assuming you keep the total calories down and change from not only reducing carbs, but improving or increasing the amount of poly and monounsaturated fats that you have, at the expense of carbohydrate, that is an option that's available to you when you come and see me. If that's the sort of person you want that you present with and the sort of food that you like, that would be an option that I could give you.
So look, what I'm going to do is to go to someone else now, but thank you. I wasn't aware diabetes was going to be as hot as this as a topic, and it stirred me and woken me up. Was anyone else getting a little bit sleepy? And now you're all alert. This is tremendous. That's my brother. I planted him.
Hello, my name is Sandra, and I just wanted to ask just a couple of questions about the bacteria that you might have in your stomach and how that can affect your blood sugars and how you may change your diet in effect to that bacteria that you may have.
Thank you. Who would like? Thank you.
I'll have a go, mate. No.
We don't all have to answer every question because we've got lots of people.
Okay, so the answer to your question is, I think, there's certainly, we have many bacteria in our gastrointestinal system. It's not they that in fact will lower your sugar levels, or rather, which will not. It's not they that in fact will assist you in managing your diabetes. If you don't have diabetes, the bacteria in the gut generally don't break it down. So really what I'm trying to say is that the microbiome, the analysis of bacteria in the gut, is a growing new area, and to the best of my knowledge at the moment, it is not something which you can usually use to manage diabetes per se. That doesn't mean to say that in the near future, with further research, someone will come up with a way of achieving or assisting in that particular process.
Did you want to comment just quickly? Yes, thank you.
Just to add to that, as far as bacteria is concerned, feed them. You know, it's been an area that's been totally ignored for many, many years, and as Prof. Tuch was saying, it's a new area. Feed your bacteria. How do you do that? Don't cut out all your carbohydrates. Don't cut out all those carbohydrate foods, because if you cut all your carbohydrate foods out, what are you left with? You're left with protein and fat. Zero fiber. You're not feeding the gut. You're not feeding those bacteria, which have a lot of benefits, and we're going to see a lot more of it in the future.
Amanda, do you want to comment? Thank you. What I'm going to do, there's a gentleman right up the back, and I'm going to go to him, but just first, I want to get our audiologists out the front, because if you could come out, my audiology team, I'd like to introduce Dr. Selene McNeil, who's a clinical audiologist, and also Dr. Louise Collingridge, if you wouldn't mind being on this side, Louise, who's also an audiologist and involved with Independent Audiologists Australia. We've already heard about the impact of peripheral neuropathy. Come forward in television, they say, find the light. So that the difficulty that means we need to have a good podiatrist, and we'll come in a moment to the issue of what happens to the eye. I wasn't as aware of the ear, so tell us, what can be the impact of... No, I don't let you have your own microphone. I'm so sorry. I'm having a little bit of trouble tonight, but luckily I'm completely irrepressible. Tell us what impact diabetes can have on the ear. Is I'll hold it.
Okay. Sorry, as an audiologist, I'm so used to hold a microphone.
Yeah.
Okay, so the hearing is affected by diabetes in the same way as the eyes are affected, in the same way as the feet are affected. It's by lack of good blood supply. So the hearing system, the ears, is a highly vascularized system. So it means there's a lot of blood flowing to that system. So if that system is impaired, the vascular system is affected, hearing will gradually deteriorate.
So what's your advice to those people who put their hands up earlier to say that they have diabetes? What should they be doing?
I think they should have had their hearing tested, because hearing loss is a very gradual and a very subtle process. So I just want to say, first of all, 1 in 6 people in the general population have a hearing loss. So it's quite high prevalent. But when you talk about a population with diabetes, this doubles to 2 in 6. So it's much higher the number of people with diabetes and hearing loss. So you may already have a hearing loss as you would have because of the aging process, because of noise exposure, but if you have diabetes, your hearing loss is even.
My understanding is that it's important to get a hearing test to have a kind of baseline, and then you go every few years, whatever, and you can check if there's deterioration. Can you explain that importance of a baseline, or should I come to you, my silent friend? No.
Well, the thing about hearing is it's very difficult to say you've got a hearing loss because sound is a changing environment. So whilst you may feel your hearing has changed gradually over time, your baseline in your mind isn't really a reality. So you need a baseline hearing test to put that on paper so that you can compare that. And the only way really is to have a professional hearing assessment conducted to get that baseline.
So where do you find audiologists?
Well, audiologists are, unfortunately, within the state health department, there's not much audiology services available. So you can find audiologists in the private sector, and there are many audiology clinics, but there are some that are primarily focused on hearing aid sales. Now, that's a different thing to seeing a clinical audiologist. So that's why we brought along a clinical audiologist this evening.
So explain what a clinical audiologist is, please.
Well, we look at diagnostic more than rehabilitation. So a clinical audiologist will do assessments to try to find out if you have a hearing loss, and if you do, what degree of your hearing loss is, and what is causing that hearing loss. Because different things can cause a hearing loss. Some can be treated medically, and some cannot be medically treated or even reversed. So, and a clinical audiologist can also provide rehabilitation. And rehabilitation of hearing loss, it's not only hearing aids as a lot of people think. Hearing aids play a very important role these days. Hearing aid technology does a lot for people with hearing loss, but depending on your level of hearing loss, you may not need a hearing aid yet, but you may already be experiencing hearing problems. And there are things that we can do in terms of some exercise, that's what we call auditory training, that can, once we know the sounds that you cannot hear properly, we can advise you on what you can do to improve those sounds. And I'll tell you one thing here that you can learn from tonight. If you have a high frequency hearing loss, to have a microphone is not going to help. So it doesn't matter how loud the sound is, it's not going to be clear. So it's not just about making the sounds loud, but you need to equalize for the level of hearing that you have.
Could I ask you, some of these people will have contact with St Vincent's Hospital, and I'm aware there in St Vincent's Public, there is an audiology department where I had a cancer in my head and I was referred there for assessment. And that didn't cost anything. But does that require a referral from a doctor to have access to a centre like that within a public hospital?
In the public hospital, usually if they are publicly funded, you don't need a referral. But if there's Medicare funding, then you will need a referral. Because to access audiology services, to access hearing tests, to get a rebate from Medicare, you need a referral.
Thank you very much to both of you, and if there's any questions, I'll come to you. Would you please give them a round of applause? And I might just hear from our optometrist, so we are aware of the full range of allied health options we have for questions. Do you want to introduce yourself and explain what you do?
I'm one of the optometrists at the Centre for Eye Health, and we're an advanced imaging centre. So what we do is diagnose eye disease pretty much day in and day out. So I don't work as the typical optometrist selling glasses.
And where is your centre?
So it's located at UNSW campus in Kensington.
So what's the link between diabetes and problems with the eye? Because that's a big issue, isn't it?
I think this is probably the least controversial part of the evening, actually. It's pretty well established that diabetes can cause, well, let's just talk about the most common cause of vision loss in diabetes, which is diabetic retinopathy. The retina is the light-sensitive layer at the back of the eye, like the film of the camera. So it contains a very important central part called the macula, which is where your central vision occurs. So one of the two major problems that diabetes can cause is macular edema, which is where it's kind of similar to with the audiology problems that can occur. The blood vessels become damaged due to the high blood sugar levels, and the retina becomes a bit starved of oxygen, and the blood vessels break down and start getting very leaky. So when we get leakage of the blood components of the blood into the retina, it can cause it to swell, and that can cause the vision to start getting blurred, and that can be, if it's there long enough, it could be a permanent vision loss and distortion of the vision. So that's called macular edema. And that's the most common cause of vision loss in people with diabetes. But there's also another much more severe problem called proliferative retinopathy, which is where the blood vessels kind of shut down, actually. The retina becomes so starved of oxygen that the retina begins to grow its own new blood vessels, which sounds quite clever. except that these blood vessels are very leaky and they can bleed and fill the eye with blood essentially. And that can happen really quickly. It can happen literally overnight. So one of the main take-home messages with diabetic retinopathy is it often causes no symptoms until it's very severe, which, yeah.
Well, obviously we have a room with a lot of people with diabetes, and this is rather distressing information. So, no, you have to inform us, but I'm just thinking, what can we do if we have a diagnosis of diabetes to try to prevent vision loss?
There's a few things that you actually have control of that you can do, a few things you can't change. But the most important one, well, two most important ones are controlling the blood glucose levels, blood sugar levels, as much as you can, because that's been strongly shown to reduce your risk of getting diabetic retinopathy. But having regular eye examination is so key because it doesn't cause symptoms until it's very severe, and we want to pick it up much earlier because it can be treated at, we don't want to wait till severe vision losses occur before we treat it because it's difficult to undo the damage. The other thing is to control the blood pressure as well. It's actually linked to progression of the retinopathy as well, and cholesterol levels, somewhat linked as well.
And so, where do I find a you? Because you're not the average optometrist, are you?
No, but actually the average optometrist is quite capable of performing a dilated eye examination, which is the gold standard way of checking for retinopathy. So that's where an eye drop's put into the front of the eye, and it dilates the pupil and basically gives us a big window view into the back of the eye. And every optometrist in Australia is trained to diagnose retinopathy.
So is it a similar message to audiology in that we should see someone, get a baseline and then have regular checks, or is it slightly different?
Well, the recommendation for someone with type 2 diabetes is to have an eye examination at the time of diagnosis, because as Professor Tuch said, they might have had diabetes for quite a while without even realising it. So the risk of actually having retinopathy is already quite significant. And then it should be every 1 to 2 years, depending on the risk factors, or more frequently if we start to find retinopathy there. With someone with type 1 diabetes, I should say, you either need to start having your eye exams at puberty, because that's been shown to kind of increase your risk of getting retinopathy, or 5 years after diagnosis.
Is there anything else that you need to tell people?
Medicare covers eye examinations for people with diabetes above and beyond what the normal, the normal eye examination is what I meant to say, not the normal person. So someone without diabetes can access a eye examination every 1 year after the age of 65, or every 3 years below the age of 65. But a person with diabetes is able to access a Medicare-covered examination really as frequently as they need, and that covers the dilation of the pupils and examination of the back of the eyes. So that's a really good thing to know about.
Thank you so much. Would you give her a round of applause too? Thank you. What I might do now, if it's okay, is go to questions. I think that's our best bet. And there was a gentleman right up the back. Are you still there, sir? I'll come up to you. And then I might work my way down and over to the other side. So please take this opportunity to ask. This will be our final question session.
I was very glad when the discussion was around the dietary factors involved in diabetes. And while it's important to look at all research, including older research, there's wisdom to be found in ancient and modern sources. I just thought just to refine the discussion a little bit more about carbohydrates, I think that more recent research indicates that it's actually particularly fructose that seems to be the problem. I can quote just very briefly from a journal called Intensive Dietary Management from September 2014. Fructose causes insulin resistance, hormonal obesity, and just very briefly, the metabolism of excessive amounts of fructose leads to fatty liver, which is a key step in the development of insulin resistance, as we saw in our last post. Is there evidence that consumption of fructose leads to insulin resistance? In a word, yes. As far back as 1980, there were studies linking the use of fructose, but not glucose, to the development of insulin resistance in humans. So I just thought if you'd like to make some comments, particularly about fructose.
Could I come to Amanda first, if I may, please?
Well, I'm a nurse and a midwife, so not a qualified dietitian, but there is definitely, fructose comes from fruit, So as Nasseem said earlier, there are vital micronutrients and vitamins that you need. So I would never recommend getting rid of all fruit altogether, particularly in pregnancy. Women need 2 to 3 serves a day whilst breastfeeding. So there is, again, you're going to have some of it, but I can't comment on exactly how much and that particular piece of research because it's not my area of expertise.
Thank you. And Dr. Malouf, would you like to comment? Thank you.
As Amanda was saying, fructose in fruit form, no one can overconsume on fructose from fruit. How many pieces of fruit can you eat a day? If we all ate fructose in its natural form, no one would have a problem. And that research was totally irrelevant. But when you're eating fructose in concentrated forms, it might have an effect, just like glucose in concentrated form has an effect too. So it's a refined carbohydrate. Yes, it is metabolized differently from glucose. It goes to the liver and it turns to fat and it does all the things that you're saying there. But unless you're eating fructose in concentrated form, you don't have to worry about that so much. Eat your fruit, get your fructose in the quantities that we're supposed to be eating, and you won't have a problem.
Yes, Professor, did you want to comment?
Nope, that's fine.
Thank you. This gentleman just wants to make another comment.
While I fully agree with all the comments about refined carbohydrates, it is known that certain fruits, which do have a very high fructose content, such as dried fruits and dates, in excessive consumption, lead to exactly, the blood recognises it exactly the same way. Fructose is fructose wherever you get it. And it's known from ancient, I can quote from ancient Jewish sources, from Maimonides, who recommended very low consumption of dates. There's other sources where similar comments are made, I'm sure, in Ayurvedic medicine and other things, and macrobiotics in particular avoids excessive consumption of fruit. There's fruits and there's fruits. There is things like watermelon, which is wonderful, and other fruits which are low fructose and have lots of fibre and other nutrients, but there are certain dried fruits and other fruits which have excessive amounts of fructose, which I think some people should avoid.
Just before you answer, you are present at an event co-hosted by Wolper Jewish Hospital. And if you take on Maimonides, be careful. Isn't he a highly esteemed Jewish writer of the past? I'm joking, sir, but is the critical factor fresh fruit rather than dried?
Look, when you're drying a fruit, what are you doing?
Up in the sugar, right?
You are concentrating the sugars. It's only got sugar in it and water. So when you eat 20 grams of dates, you're eating almost 17 or 18 grams of sugar. Now, yes, it does contain fructose. I don't know why you're separating fructose from glucose. The total issue here is that all fruit, they vary. The proportions of fructose, glucose, and sucrose vary from fruit to fruit. It is a contributor to what we call the glycemic index of carbohydrate foods. And to your information, watermelon is worst of all. Not in terms of the fructose, but in terms of how high it raises your blood sugars. So it's one factor of many that you take into account.
What I'm learning is I need a diabetic educator and a registered dietitian, don't you reckon? As well as you, sir, Professor, because it's complicated. It's not as easy as you think. But Professor Tuch, did you want to comment?
Yes, I did actually. Julie, I just want to comment about you. You see,
you're not talking about my
what have you noticed? What have you noticed? What Julie's doing tonight? Walking up and down the stairs, isn't she? She's trying to reduce resistance to make sure she doesn't get diabetes in the future.
That is so true. Sir.
Thank you, Julie. I've been put on dietformin many years ago when it was first discovered that I got diabetes, type 2. But I've noticed over a period of time, for a long time now, that I'm not digesting my food fully by simply observing my stool, looking for blood spots, etc., etc. And I've noticed that I have lost weight, not necessarily from exercise, which I do. Is there a connection to the digestive system? And perhaps, and the second question is, dietformin we've been told that some sort of a super drug and a youth pill. Is there any connection to that and also to the digestive system?
So let's just address the first part. See, I have memory difficulties getting onto all the questions, but let's deal with the first part. So is there an effect of metformin, which is a tablet used in the early treatment of type 2 diabetes, on the gut? And the answer to that question is absolutely. You can get side effects from metformin, bloating, diarrhea and vomiting. Second part of that question is unrelated to metformin, diabetes can adversely affect the unconscious nervous system that supplies the gut. So you may have a difficulty in with it such that you won't absorb. Delayed gastric emptying can occur and can cause you all sorts of problems. That's got nothing to do with the metformin, but it can be, if you get your sugar levels as normal as possible, you can reduce or minimise that adverse effect. Now, was there a second question?
About being a youth pill.
Is it a youth pill?
Metformin, my goodness. You are as young as you feel. I think Maimonides said that, didn't he, back in the 12th century? But the answer to that, metformin certainly has turned out to do many things. It's supposed to reduce the risk of bowel cancer. It's currently not necessarily recommended to take it for that purpose, but it has a number of effects beyond that of lowering blood glucose levels and reducing insulin resistance. Youthful, you're as young as you feel. I've never seen the connection between the two, and I'll leave it up to you to tell us if in fact you believe it makes you more youthful. Are you feeling more youthful?
I do, actually.
He looks about 12. This side of the room, I don't want you to feel neglected. Has anyone got a question or a comment? Yes, could you just wave at me so I can see? Down there, I beg your pardon, I'll just come over. And there's no one up here just before I go down. Not that I don't want as much incidental exercise as possible. Oh my God. I'm sure I've put on weight since the last time I was here in this theatre. Where's the lady? Thank you.
I was just wondering about high fructose corn syrup. It seems to be in a lot of the products. Does that increase the incident, increase the elevation of sugar levels?
Well, of course, it's a sugar, isn't it? So it's metabolized a little bit differently, but yes, it will affect your blood sugars, particularly when you're eating it in that concentrated form. The Americans, it's a big problem in America because they add fructose syrup to everything. So yes, is one of the issues over there where people are getting a lot of refined carbohydrates from those concentrated forms. If you can avoid it, you're better off in having your fructose in fruit form.
There has been, as you're probably aware, a number of very high-profile documentaries analysing the amount of sugar, particularly in the United States, that's been added to all foods, and to some degree here in Australia. So I think this emphasis on, particularly on corn syrup in American food, has been highlighted as a real problem.
I just wanted to divert. I think you've actually raised the issue. Currently in Mexico, there's a tax on sugar. There is no tax on sugar in Australia for a variety of reasons, and I was curious to know if a referendum was to be, and that's not likely to occur for such a matter, but if it was, how many people would vote in favour of introducing a tax on sugar? Please raise your hand. Interesting, about 50%.
Let me just get this lady to comment here.
America uses high fructose corn syrup because it is a lot cheaper, whereas Australia produces some, and it's a lot healthier sugar to high fructose. But it also says it's made from wheat. Is that the same thing when it's made from wheat?
I'm sorry, I don't have an answer to that.
No, you won't get fructose from wheat. Starch comes from wheat, which is pure glucose. You don't get fructose from that.
But can I just say, just very quickly, just as an aside, I do think there is a political dimension to this because there are congressmen for whom their constituency produce the corn that makes the syrup, and here in Australia, there are National Party members, particularly in Queensland, who have high sugar farmers represented in their electorates, and it can be very difficult for them to take a public health step, such as, for example, a higher tax on sugary drinks, because we're told if we could eliminate them, that is enormously helpful. We're almost at the conclusion. I'm going to take 2 more questions, because finishing on time is a beautiful thing, particularly on a cold winter's night. But I saw a finger. I'm sorry, I'll just come to this gentleman because he hasn't asked before. And if there will be a special prize for anyone who can bring Maimonides into the question.
Thanks, Julie. Yes, so when Dr. Tuch brought up a tax on sugar, I think that's for manufacturers, so to encourage manufacturers to lower the amount of sugar in products. So that's really my comment, and more so than adding another 50 cents to retail products.
If I may comment just quickly, I think it's both, because just as they've increased the cost of cigarettes and alcohol, it reduces consumption. I think there's evidence that if you raise price and reduce access, you drop use, you drop consumption.
But showing it that the manufacturing is perhaps more the issue because there's so much sugar in products. And
well, of course, it is one of probably the single most common additive besides salt. It's added to our processed foods. So the less you eat of the processed products, the better off you are. When you go to a supermarket, if your trolley is largely filled up by packages and cans and whatever, that's something you really shouldn't be doing.
We've got two more.
I just want to mention that I have been a patient of Dr. Malouf, and he's the best dietitian ever. I really recommend him. I just wanted to ask, it was said to me last week by someone that if you have diabetes, you can't have cortisone. It sets the diabetes mad. Is that so?
Yes, and the answer is cortisone will increase insulin resistance, but if you need it, for example, you need a steroid injection or you need to take it for your asthma, then you take it and we increase the insulin that you'll need to take or tablets that you would. So the short answer is yes, but it's you take it because you need it, and if you need it, we then increase the anti-diabetic medications accordingly.
And I'll just have the final question here.
We've talked a lot about bodies and what effects it has on the bodies, but I'm wondering how much research is actually done on the brain.
Impact on the brain of diabetes and memory loss.
So I guess the answer to that is that's research in progress at the moment. There's a gentleman a geriatrician at Prince of Wales Hospital called Associate Professor Gideon Kaplan, who's investigating exactly that question at present. And the relationship between insulin resistance and dementia, or delirium in particular, is what he's interested in, and how do you actually prevent and overcome that particular situation.
Ladies and gentlemen, I just want to say to our panel and to our audience panel, thank you so much for coming. I'm going to get them to clap you in a minute, and there's a present for you, but I'd also ask you to gather at the end of the evening in front of this light, and we'll have a group photo taken for the Wolper newsletter. But could you please thank them for coming out and speaking to us tonight? And I sincerely thank you for coming out. It's such an important topic, and I know it's very cold weather, but I'd like to hand back now to Dr. Schell to close our evening. Thank you.
Thanks very much, Julie, and thank you to our panellists. I'm actually an expert on dementia. I've been working with Professor Henry Brodati for the last 7 years, and on the answer to that question, I'd have to say that if you want to reduce the potential for memory loss, then you must manage your diabetes well and your blood pressure and do your regular exercise. So I think that, yes, Gideon may be doing some research, but I think what is evidence is that if you do have some comorbidities, such as diabetes, blood pressure, etc., then you should manage them well, and that should reduce the potential for you to develop dementia, and or if you have vascular type dementia, perhaps slow it down. That's my comment, so thank you. I just want to say thank you to all of you for being here this evening. Our next meeting or evening will be on the back to a Wednesday the 13th of September. We're going to talk about cardiovascular disease, which happens to be a very large topic amongst most of you, I'd say. And certainly we'll have another one at the end of the year as well. So I want to wish you all a very good evening. Please look at the information that's out there at the back by the NDSS. And thank you again for coming along tonight, and we hope to see you next time. Thank you.